I wanted to hear from some of the faith organizations who are here today to share some of the work that's already happened. We're going to take all of the tools and examples and sort of grounding information that we got this morning, as I'd mentioned, and this afternoon when we go into these working groups, we're really going to talk about solutions and recommendations and things that actionable items. But it is exciting for us to hear about the successes and interesting work that's happened. We're first going to start with Jeff Hale, who's getting wired as we speak, not tap wired. He is the director of legal advocacy at World Vision, and I can stand up here and tell a few more jokes while he gets wired up. Let's see. You all set? Okay. So thank you, Jeff.
Hello. Should I use this? This mic's on, right? So I can just use it? Okay. Oh, I see. Great. Good. Okay. Well, hello, everybody. It's a great pleasure to be with you all today. And from all of us at World Vision globally, many thanks to our organizers, USAID, UNICEF, Georgetown University, for organizing this important event and for your partnership throughout the years. Today, I'll be introducing an approach that we call citizen voice in action. I'll quickly run through the approach here. We'll look at some evidence of effectiveness, and then we'll look at the way that faith communities can be pivotal to the success of social accountability approaches like citizen voice in action, or CVA. So, what is citizen voice in action? So CVA is a social accountability approach, and it's designed to improve the relationship between communities and government in order to improve services like healthcare, education. Now, ultimately, those improved services should impact the daily lives of children and their families. So how does it work? Well, we divide CVA into 3 phases. We begin with civic education, which we call enabling citizen engagement. Then we move into a monitoring phase that we call the community gathering, and then finally an advocacy phase that we call improving services and influencing policy. So in this first phase that we call enabling citizen engagement, we begin from this human rights perspective and educate communities about the right to health. But we seek to draw the right out of the abstract and make it tangible for real people and real communities by articulating how that right translates into a community's daily life under local law. So, for example, in Indonesia, the right to health under local law might be that you have the right to have a midwife present during certain hours of the day at your local clinic. Now, next we move into the monitoring phase of CVA, which includes 4 participatory meetings that we call the community gathering. And using an adaptation of the World Bank social audit tool that we call monitoring standards, communities visit brick and mortar facilities, places like clinics or hospitals, and quantitatively measure and record the difference between reality and what should be there under local law. They record it all in a standardized sheet, and in this example here, you can see that government policy said that each clinic should have a midwife, but this clinic did not. Now, we know that objective quantitative data is not enough to properly describe the condition of a service, so we use an adaptation of a community scorecard, originally developed by our friends at CARE, to offer communities an opportunity to develop their own subjective, qualitative criteria about what they would like to see at their schools or clinics. So in this example, focus groups, including the most vulnerable, prioritized the availability of drugs and staff friendliness. They then rated the clinic's performance on a 5-point Smiley scale, which is, of course, friendly for children and for illiterate groups. Finally, with all this evidence, CVA practitioners convene a town hall-style interface meeting where they present the results of their monitoring exercises. And this is a big deal. It's ordinarily a new civil society space, and the meeting might take a full day and may include up to 200 people, including citizens, faith leaders, faith communities, service providers themselves, and local government. At the high point of this meeting, the stakeholders commit to a simple action plan. And to help ensure that stakeholders fulfill their commitments, World Vision equips local partners with a simple set of advocacy tools. So in a nutshell, that's how CVA works. The Citizen Voice in Action has now been scaled to 227 of our 1,800 area development programs in 34 countries around the world. And when operating at full speed, each of these programs serves between 25 and 50,000 people. We're exploring how to scale to all of our 1,800 programs. Now, believe it or not, it's difficult to find that kind of consensus in an organization as large as ours. So what's brought about this rare event? Quite simply, it's the evidence of impact on child well-being. So what you see here are results from a randomized control trial in Uganda that examined the impact of an approach similar to CVA. And in 25 communities, we applied CVA, and in 25, we did not. They served as a control group. After 1 year, the researchers measured the differences and found remarkable impact, including a 33% reduction in child mortality in the treatment communities. Importantly, 4 years later, these results seem to be holding. Now, it's important to point out that CVA is an agenda-neutral approach, so we see similar results with respect to education. And for these results, we owe a word of thanks to Andrew Zeitlin and his colleagues here at the Georgetown Public Policy Institute who carried out this study. Randomized control trials in Uganda showed that primary test scores rose by 9% in the treatment schools that were using the CVA scorecard. The communities were also 16% more likely to solve collective action problems. Now, I know that we either love or hate RCTs, and if you're interested in our broader research agenda, then please ask me during the Q&A. But it's probably at least worth mentioning here that our own program data seems to resonate with these results and points to some level of generalizability. If you're interested in our own results, you can pick up this publication for me after the event. Now, finally, a few words about the role of faith leaders in this process. Now, as part of our regular operating model, World Vision routinely engages faith leaders to join and lead the development process. But we've found that in the case of social accountability and local advocacy, the role of the faith leader has become much more important. They provide legitimacy, credibility, they broker relationships, and they enhance sustainability. Now, Isaiah Matimba is a church leader in the Zambian community of Mashikili and a district convener for the United Church of Zambia. Since 2010, Isaiah has been actively participating in World Vision's Citizen Voice in Action approach. Now, using the approach, Isaiah and his colleagues began by raising awareness about the community's entitlements at their local health center, and in particular, they focused on translating Zambian health policy into local languages and researching staffing commitments at the rural health center in their area. Now, Isaiah's communication skills, acquired at least in part because of his ministry and his recognized leadership, equipped him to play this vital role. Now, one of the first things that he and the Mashikili villagers discovered was that many community members had a deep distrust for the clinic staff. They seemed rude and distant. These opinions were reflected when we went through the scorecard approach. But through the CVA process, Isaiah helped to broker direct dialogue between community members and clinic staff in a way that would not have been possible for the average citizen. Staff tell us that it was his credibility and legitimacy in the community that allowed him to play this role. Clinic staff trusted him to lead a worthwhile process. Now, in the end, it was apparent that the clinic staff were always unhappy because they were so overworked and understaffed. Imagine what it would be like if you had to turn away your sick neighbors because you didn't have the right drugs or the proper staffing. Now, Isaiah and his colleagues determined that under local law, the clinic should have an environmental health officer. This is a type of community health worker who deals with prevention mostly. Now, working collaboratively, they brought the evidence from the CVA process and the evidence of the impact of the absence of that worker to the district health officer. Through their advocacy, the new health officer was posted within a month. Today, just 1 year after the posting, and thanks at least in part to the work by this new staff, births attended by midwife have risen by 7%, and immunization has risen by 3%. Now, there were other successes as well. The community worked to eliminate user fees at the clinics. They guaranteed that pregnant women would receive free materials. And Isaiah led another successful lobbying effort by which they persuaded a cell phone provider, a cellular service provider, to construct a tower in the area. And today, the clinic staff can call the district when they need help in an emergency. But perhaps most importantly, the relationship between clinic staff and the community has been repaired. We view each other as one, said a nurse in a recent interview. And in all our interviews with community members, it is clear that the legitimacy, the credibility, and the brokering skills that Isaiah provided were essential to the success of the intervention. And this work can continue long after World Vision leaves because the church is here to stay. Let me end there, and thank you very much for your time.
If there's any questions or comments for Jeff? No? Okay. Thank you so much. Next, we're going to hear from Milani Kabadij, okay. Yeah. The Regional Technical Advisor for MCH of World Relief. And in a fabulous outfit, I might add.
Thank you very much. Thank you very much. I'm very glad to share with you the experience with Burundi. From 2007 to 2012, World Relief and USAID have implemented and funded a program, a child survival program in Burundi. And the name of the program was Ramba Kibondo, meaning live long. The project was implemented in Kibuye Health District, situated in the center of the south of Gitega province and in the center of Burundi. As you can see with this picture, there is a baby face smiling. Is a Burundian baby and is happy and he's expecting to live longer. Why? It is because her mother is just fulfilling the 10 promises for saving her child. How that did happen? From this graph, you can observe the achievement for the program through by the program implemented by community members, and the result, the achievement expressed by these graphs. In red, it is the end of the program evaluation. In blue, it is the baseline. I can confirm that the program have achieved 9 out of the 10 promises to save the children, and they have really reached a spectacular result. If we can see, for instance, for the children fed to minimum standard, there was really a dramatic increase from 25% to around 90%. And for ORS, home fluid preparation from home, and during the diarrhea episode, you can see that there is really a significant increase it is around from 42 to 85%. It is really a significant increase. For care seeking, during fever for acute respiratory infections, mothers also have changed their behavior. They are seeking treatment, retreatment at the facility level, and you can see the increase is sharply from 50 to around 90. This is really a significant increase because of the model that has been implemented in Burundi, named care group model. It is a fantastic model, and it was being implemented with community volunteers and with the collaboration and integration with Ministry of Health, community health workers, and with also support from church leaders. The model is very fantastic. It is equitable. It is affordable. It is sustainable and scalable. Yeah, care group is a group of 10 to 15 indigenous health volunteers. They meet regularly in monthly or bi-weekly meetings together with the project staff for supervision, for training, for support, and for M&E. Each volunteer is responsible to train over 10 mothers outside the group meeting. To train the neighbors, 10 households, 10 mothers. This is the structure of the care group model. In Burundi, in Kibuye Health District, the model has been implemented, and around 190 households was reached. Each volunteer was conduct training in 10 households, and all volunteers, around 3,000 volunteers met together, were joined in around 230 care groups. They met together, they were sharing together, they were trained together in small group, as I said, in 10 to 15 group of volunteers. And then they were trained by promoters who are staff, project staff, and supervisors who are responsible for coordinating the activities. Those volunteers really are our heroes. They are very committed to change their own communities by promoting behavior change, by promoting a good habit that nurture mother and children health. Besides care group, the program have been implementing care group for local church leaders. And 3,000 local church leaders were also met together in 30 care groups. They met together on a monthly basis. They met together to learn about BCC, behavior change communication. They met together to plan where the key message that should be shared through the congregation. They used to take 5 minutes at the end of the sermon to share with the congregation about the best behavior, helpful behavior. And those strong leaders, church leaders, were more involved in family planning and birth spacing. because at the beginning of at the end of the project, they were together and they were invited to a big conference at province level with officials, with more than 100 church leaders to talk about family planning issue and to talk about birth spacing. And then after the conference, they were really well committed. They were committed to talk about it. They were open to discuss with the congregation. And just in 6 months, we have observed a great and high impact in child spacing. The rate of family planning use was dramatically increasing from 80% to 42%. You can imagine how it was really wonderful. And I think, and I trust it is because of the involvement of the church. The integration of Minister of Health, Community Health Worker was also effective. All community health workers were involved and were integrated in the care groups. We have 170 community health workers integrated in a care group. And because of the integration, they were also educated to share the health message through with community members. They were educated the good way to communicate with the community. And based on that, USAID Global Health Initiative Strategy for Burundi included care groups as a best practice approach to disseminate key messages in the community using local volunteers. For monitoring and evaluation, sometimes we think that church can't do monitoring and evaluation. Sometimes we don't trust that they can be able to do that. But while church members or church leaders are well trained, they can do, and it was feasible in Burundi. Church members, church leaders are collecting with volunteers. They are collecting monthly data. They are participating to some periodic monitoring surveys. They are also participating to household surveys for baseline, for midterm, and final evaluation. They are responding to some qualitative inquiry, to explaining the result of the project. And also, the responses are very helpful to plan for the intervention, in order to improve the intervention. And we have specific data collected specifically by the local church leaders, like how many people they have reached by BCC, how many vulnerable families they have helped in order to change, to adapt the new behavior. And all results we have are shared through all the partners, are shared with leaders, with the Ministry of Health, and with church leaders. As I have mentioned, the program ended in 2012. The grant finished, but we still have to continue the work. The work should be continuing, and we have next opportunities. And I think the church is not leaving. The church is still there. They can continue with that, the work done. and it is what is happening in Burundi. The care group have pertaining with a local Christian organization, Dutabarane, and tried to integrate saving groups for livelihood in order to empower the volunteers while they are continuing to take care of the community members. And in addition, UNICEF have funded the care group for community case management to integrate into care group the community case management, and also to scale up not only in Kibuye Health District, but scale up in 2 more health districts. And because of the success of the care group model. And PDF really can fit. It is fitting well with the faith community to lead that activity at community level in order to prevent malnutrition and to prevent severe malnutrition and to prevent malnutrition in the next generation. The curriculum for Families for Life is a best curriculum, and it was shared with care group members. And now, church leaders are equipped to share the content of the curriculum with the congregation member, with the young married couples, in order to involve more fathers, men, in child health, in child feeding, and in child spacing. Because, as you know, there are sometimes things that it is not, it is the job of the woman. And this curriculum is very helpful and easily used by church. And it is possible to scaling up the care group model. I think as faith community together here, and as we are renewing the 10 promise, I think there is a way, there is a possibility. I trust that church can really reach the 10 promise and keep the children smiling. Thank you very much. Thank you.
Thank you so much. Saving lives and looking beautiful. Okay, our last presentation before we break for lunch, and then our exciting group work, is from Sandra Fletcher, who is a technical advisor for program monitoring at ADRA International. Thank you.
Okay. Good afternoon, everyone. Can you hear me? Good afternoon. My name is Sandra Fletcher. I'm the technical advisor for program monitoring for ADRA International. As you can tell by my accent, I hope I don't confuse anybody by using different words to explain things. I'd like to thank you for this wonderful opportunity to sort of give you a clip of what ADRA is all about. I briefly want to talk a little bit about ADRA, and my focus will be more on the processes. I am a M&E person, and we love processes, so I should briefly go through a few things with you there. ADRA stands for Adventist Development Relief Agency. It is a faith-based organization. I just want to tell you a little bit about our history. ADRA started it wasn't created as ADRA, it was Seventh-day Adventist Welfare Services, created in 1956. For approximately 20 years, SAWS, as it was then known, focused mainly on disaster relief projects. Now, we only worked in approximately 35 countries at that time. In 1984, we reorganized and became ADRA International, Adventist Development Relief Agency. As I briefly said, we started off in 35 countries. We now have a presence in approximately 130 different countries worldwide. Now, our mission statement will give you a little bit of idea of our approach. ADRA works with people in poverty and distress to create just and positive change through empowering partnerships and responsible actions. That is what we try to portray in the programs we actually are involved in. Our vision statement informs us that ADRA is a professional, learning, and efficient network that embodies integrity and transparency and reaches across boundaries, empowering and speaking out for the at-risk and forgotten. Now, we don't only just focus on Christian communities. We are there to help those who are in need, in spite of gender, in spite of race or creed. Our ADRA's work. We work in different areas. We work in the food security, income generation, primary health, disaster relief and preparedness, and we work with IDPs and refugees. Now, the first three that I mentioned, which is food security, income generation, and primary health, we have a tendency of integrating that in our programs. So, for example, if we're working in the area of food security, you'll find that we also have an element of rural income, of agriculture, we have an element of natural resource management, maternal child health, health and nutrition, and WASH. So you'll find certain elements of these particular themes in our work. Integrated programs. Now, I just thought I'll give you just a clip of what the types of programs that ADRA is actually involved in. And Bolivia Food Security Program is one of my favorites because I was actually the monitoring and evaluation specialist for this particular program. It integrated agriculture, natural resource management, and also health and nutrition. And what we need to remember is that when we are working in agriculture, we also need certain aspects of health and nutrition involved in that, so that the farmers do not only just grow crops just for commercial use, but it's also crops that can be beneficial to their families, to their communities, and most importantly, for the nutrition element of their family. Another example of our programs is a slightly different one. This is our program in South Sudan, and it's the Integrated Service Delivery Program. Now, this program, we're actually working with the local health authorities and working with their health facilities. We try to do, one of the main aim is to strengthen the management of the primary healthcare service delivery. So by this, we're supporting the MOH, and we're also strengthening their health staff. And the last program I just want to highlight is our program in Yemen, which is a slightly different program than what we're accustomed to dealing with. And that's our food assistance project, where we are actually working with displaced peoples in Abiyan, in Yemen. And we're working with displaced peoples and also the communities who are hosting them. Now, with the families who are displaced, we are giving out vouchers. But we're not only giving out vouchers, we're taking it as an opportunity to give them health and nutrition awareness messages and hygiene messages also. All our approaches to our program is a community-based approach. And by that, I mean from the very beginning. The community is involved in the beneficiary selection. We train members of the communities. For example, you will have leading mothers, you might have leading farmers. We will be training them so that it provides some sustainability once we move out of that community. We have community volunteers. We also work upon building upon existing systems. So we're trying to strengthen the systems that are already there. So once we leave, once again, it will be sustainable. Sustainability is an angle of it as well, and the local government officials are also trained. Now I'm going to go to the element of monitoring tools. The 3 projects that I mentioned, there's a strong monitoring and evaluation element to it. Now I want to focus on the tools because if you have the correct tools, you're most likely to get the information that you actually want. So one of the these are just examples of, it's not an exhausted list, but these are examples that I took from the 3 projects that I mentioned. We have recorders, where these are notebooks that track referrals. We have tally sheets, registers, reports, focus groups, observations, and then we have the surveys. These monitoring tools are used to collect different indicators. You'll find that you cannot use these same tools to collect the same indicators in some instance. The collection process. The collection process starts from the grassroots level. We work with, for example, community health workers. We'll have grassroots data that is then given to our local project staff, and that data is normally sent to the national office. The ADRA National M&E team will verify this data. Now, I really want to emphasize the importance of data being verified. It's very easy to collect data, but you need to know where the data is coming from and how valid that data is from grassroots. That's extremely important. I've just recently come back from South Sudan, and I just have a little example of the fact that the need of verifying your data. Now, you will find that because there's a number of our grassroots volunteers that might be illiterate, we normally like to use tally sheets. Now, the tally sheets need to verify with maybe the registers that information is going into. And what we found was that the tally sheets and the registers are saying 2 different things. And also is the monthly reports. This would not be recognized if it wasn't verified from a team, maybe your M&E team or your field staff. Okay, all that information that's collected from grassroots, that's being verified by your M&E team, by our M&E team, is then collected and stored in our M&E database, where it's analyzed, and it can also be used. It will be used for timely decision making, to measure project performance. And when I say that, that's also good and bad performance. They both need to be measured. We all need to learn from them. To extract lessons learned, and for reporting purposes. Thank you.